Hello, colleagues. I'm Jeffrey Horbar, President and CEO of Vermont Oxford Network. And it's my great pleasure to welcome you to today's installment of Von Grand Rounds, Using Genomics Wisely. This is the second in our ongoing series of genomics webinars produced in partnership with the Rady Children's Institute for Genomic Medicine. As we all know, as we gather today, our colleagues in Ukraine are heroically providing care under the most horrific conditions. Let us just take a moment to think of them and dedicate this session to their heroic efforts on behalf of infants and families. It's now my pleasure to introduce Dr. Natalie Sweeney, Assistant Professor of Pediatrics at Rady Children's Hospital and Physician Investigator at Rady Children's Institute for Genomic Medicine, who will serve as our host and moderator for today's session. Please join me in welcoming Natalie.
Thank you so much, Jeffrey, for the introduction, and good afternoon and welcome, everybody. This is our second webinar in a series of 4 programs that we devised to explore different aspects of whole genome sequencing and provide a forum where you get the opportunity to engage with experts and get your questions answered and also share your thoughts. If you joined us in March, you participated in whole genome sequencing for newborn screening. Today, we will deal with using genomics wisely, and in the future, we will have a webinar on genomics and health equity, and also one on variants of unknown significance. So implementation of a new intervention like rapid whole genome sequencing to medical care requires careful scrutiny. It is possible that the effect of the intervention here, whole genome sequencing, may not be reflected in a positive impact on actual care. There could be increased utilization of certain services, resulting in higher healthcare expenditures, for example. The economic impact of genomic sequencing was highlighted by President Barack Obama in his 2013 State of the Union address. He stated that every dollar we invested to map the human genome returned $140 to our economy, every dollar in quotations. But how does that translate to the patient? As cost of genomic sequencing decreases, we are likely to see it play a bigger role in newborn screening, for example. DNA sequencing, when used wisely, can improve preventative care and consequently improve quality of life. But how do we use genomics wisely? What are the different issues that come into play? Furthermore, how do we navigate the ethical, legal, and social implications of genomic sequencing? To help us further explore these issues associated with genomic sequencing, we are joined today by Dr. John Zupancic, Dr. Ingrid Holm, and Dr. Russell Nufsinger. Dr. Zupancic will start us off today by discussing theme and variations on using genomics wisely. Dr. Zupancic is an associate professor of pediatrics at Harvard Medical School and associate chief of neonatology at Beth Israel Deaconess Medical Center. His research and consulting work seeks to improve the efficiency with which scarce resources are used in improving the health of children, and in particular, newborns. He has focused on performing and improving the validity of economic evaluations alongside neonatal clinical trials and on the use of computer modeling to determine best practice when evidence is currently lacking, or where empirical studies are infeasible. He is also involved in various epidemiologic and health services investigations, including the Neonatology Canon Project, a large-scale systematic review of all randomized controlled trials in neonatology over a 24-year period. Dr. Zupancic is a past chair of the American Academy of Pediatrics section on neonatal perinatal medicine. His teaching and mentorship of fellows have been recognized locally through the Merton R. Burnfield Mentoring Award, awarded by the Harvard Neonatology Fellows, and nationally through the John M. Eisenberg Excellence in Mentorship Award, awarded by the Agency for Healthcare Research and Quality. He was the recipient of the Massachusetts Medical Society's Henry Ingersoll Bowditch Award for Excellence in Public Health in 2020. Dr. Zupancic's talk will then be followed by Dr. Ingrid Holm, who will discuss the ethical, legal, and social implications, consideration, and genomic sequencing in the NICU. Dr. Holm is professor of pediatrics at Harvard Medical School and faculty member of the Division of Genetics and Genomics and the Division of Endocrinology at Boston Children's Hospital. She received her MD at University of California, Los Angeles, and completed her pediatric residency and fellowship in genetics and endocrinology at Boston Children's Hospital. In 2003, she completed the Harvard Pediatric Health Services Research Fellowship and received her MPH in clinical effectiveness from the Harvard School of Public Health. She received her certificate in pediatrics bioethics from Children's Mercy Center for Bioethics. Dr. Holm conducts empirical research to study the impact of returning genomic information in the pediatric setting. Dr. Holm was co-investigator of the Boston Children's Hospital Brigham and Women's Hospital's U19 Baby Seek project. She is currently co-PI with Dr. Robert Green of the Baby Seek 2 project U01, which builds on Baby Seek 1 to explore the medical, behavioral, and economic impacts of integrating genomic sequencing into the care of newborns of diverse backgrounds. Since 2012, Dr. Holm leads the ethical, legal, and social implications efforts as a member of the NHGRI-funded National Electronic Medical Records and Genomics Network. Dr. Holm also studies rare diseases. She is Associate Director of Roberts Program for Sudden Unexpected Death in Pediatrics, a program at Boston Children's Hospital, where she leads studies to identify genetic contributions to SUDP, and she is member of the Harvard Undiagnosed Disease Network site. Dr. Holm's bioethical area of interest is in the ethical, legal, and social implications of pediatric genomics. After Dr. Holm's talk, we will have a panel discussion where we encourage you to chat in your questions. Joining the panel will be Dr. Russell Nofsinger, who is the Senior Director of Business Development at Rady Children's Institute for Genomic Medicine. Dr. Nofsinger has been working on the use of genomics and genomic technology to advance precision healthcare for more than 20 years. Dr. Nofsinger obtained his PhD and conducted his postdoctoral training at the University of California, San Diego and the Salk Institute. Following his scientific training, Dr. Nofsinger served in a variety of commercial roles for several genomics technology companies. During his tenure, he develops clinically focused business supporting proprietary test development across a wide range of indications. Through his experience creating and expanding applied markets for cutting-edge genomics technologies, Dr. Nofsinger developed a passion for driving clinical implementation and broadening access to clinical genomics technologies. More recently, Dr. Nofsinger has spent considerable effort and time working with children's hospitals, healthcare systems, and payers to incorporate whole genome sequencing in the care of their patients and will prove valuable to our discussion today. So without further ado, I will now hand it over to Dr. Zupancic to start his presentation.
Thanks so much, Dr. Sweeney. It's a pleasure to be here. Yes, it's a pleasure to be here in large part because this idea of introduction of genomics into our community has been, I think, one of the most thoughtful and holistic processes that I've seen for a new technology in neonatology and probably in medicine since I've started practicing. So we're going to talk today about these issues of economics, but obviously it goes far beyond that to issues of ethics and equity, and those are also going to be handled either today or in other sessions. So as we said, I'm going to talk about it in the next 12 minutes about a theme and a couple of variations on it. You've probably heard the theme if you are a participant in other Vermont Oxford sessions on value. That the theme is that we're all responsible for using our resources wisely. And that obviously applies to this particular technology as well. A few numbers to set the foundation of this. This is $4.1 trillion, which is the amount of money that we spend every year in the United States on healthcare. That's a lot of zeros. It's a phenomenally large amount of money. In fact, it constitutes 20% of our economy. That means 1 in every 5 days that our economy functions. It functions in order to generate resources to pay for the healthcare of its citizens. That money, that amount of investment has been increasing at a remarkable rate. It's on average, it's about 5.4%, but in fact, it's much higher than that in the last couple of years. In fact, in 2020, it was almost a 10% increase in part due to the, or in large part due to the COVID epidemic. For our purposes, it's also important to know about this fourth sum here, which is $291 billion. That's the amount of money that is spent on pediatric healthcare annually in the United States. And in fact, in infancy, below 1 year of age, we use about 20% of that sum. So enormous numbers here, and it's up to us to think about how they are relevant at the bedside. So I'm sorry, I have to take this draw. So when we're thinking about using resources wisely, there are several reasons why we might be able to do that. The most common one that initially comes to mind is that we have to save money. Even that rationale, it's important to know, is not so much a process of saving money or generating revenue. It's in order to ensure that we can save money for a better use for our patients. There might be business cases for quality improvement that are reasons to think about choosing wisely and using resources and technologies wisely. So can we take the resources that we save and redirect them to quality improvement efforts? There are reasons of socially responsible care, just the fact that we are stewards of the efforts of society, and it's important for us not only to provide excellent care, but to make sure that we're marshaling our resources for other important medical and social goals. Today, we're going to talk about the fifth reason on here in particular, and that's to study this and to talk about it as we are today in order to ensure that new and expensive interventions are still a wise investment, and that we're, in order to do that, we want not only to talk about how much we're spending, but how much we're getting back. Even if this costs more, do I get good bang for the buck, so to speak? In order to do that, we think about this concept of value, which is essentially the how much we're getting back for any particular investment. It's the bang for the buck or the outcome for a particular cost. In the case of genomics, I'll just briefly summarize what you probably heard either in the literature or in previous sessions. Here's some information from an earlier publication of the BabySeq project from about 3 years ago. In studying 159 patients and doing genomic sequencing on them, the probability or the chance of identifying in any given patient childhood onset disease, the risk of childhood onset disease, was about 10%. The probability of diagnosing adult onset disease that was actionable is about 3.5%. You could detect recessive disease carrier status in 88%. You might detect variants that predict the response to drugs or the adverse effects of drugs in 5%. So we know that there is some significant outcome even in a screening situation with respect to whether sequencing might be a good idea and have something that we would be willing to pay for. As we'll see in a little bit, it goes beyond that. And in terms of diagnosis. But we also have to think about the cost. So this is from a modeling study that is actually in press now. The references for all of these are actually at the end of this talk. In this very sophisticated modeling project that came out of a group, a collaborative group that summarized the evidence across multiple studies for both critically ill infants and children, we see that there is a cost that's associated with the standard of care, SOC here. These are single gene tests, panel tests, the process of genetics consultation. It is around $6,000 per critically ill infant examined. The diagnostic rate summarized over multiple studies was about 9% in that situation. And then we see exome sequencing, a process of standard of care followed by exome sequencing. Here's genomic sequencing. The cost was about $12,000. And in this situation of analyzing infants who are critically ill, the diagnostic yield summarized by these authors was about 50%, and the incremental cost per diagnosis, meaning the number of dollars that you paid for each additional diagnosis you made relative to some other process, was about $15,000. Now that's actually quite an impressive number. This graph here shows what we call the acceptability curve. The curve that we're most interested in, or the curves, are the orange one, which is what we're currently doing, or what we were doing 5 years ago, say, without genomic sequencing, and the blue curve, which is the acceptability curve, cost acceptability curve for genomic sequencing. On the x-axis is how much we might be willing to pay for each additional diagnosis from genomic sequencing, and on the y-axis is the likelihood that would be the case for any particular number. And what we see is that if we're willing to pay about $15,000 here for an additional diagnosis, we have about a 40% probability that genomic sequencing would be the testing strategy that we would use. This is initial genomic sequencing before we do anything else, in combination with genetics consultation. And by the time we get up to even $30,000 or $40,000 willingness to pay for an additional diagnosis, we have an 80 or 85% chance that is a superior strategy, that we would win by choosing that as the initial intervention. That's per diagnosis made, and we get similar findings when we extend the analysis, and instead of using just the cost per diagnosis made, we use the cost per quality adjusted life year. On the x-axis here, we have the willingness to pay for an additional quality adjusted life year, and on the y-axis, again, the likelihood that a particular strategy will be the best one. And what we see is that if we're willing to pay for critically ill infants more than about $40,000 per quality adjusted life year saved, we will, then genomic sequencing tends to be the strategy that is superior. So in addition, though, to this idea of this overarching theme that we have to use our resources wisely, there's also a couple of variations that we'll quickly go through. The first of these comes from, you probably recognize this phrase that came out in the 1990s. It's attributed to James Carville and during the campaign of Bill Clinton here in the U.S. It was originally "It's the economy, stupid." I have changed it to "It's the effectiveness, stupid." And because I'm with friends, that's what I say to myself. But with you as the audience, I've changed it to "It's the effectiveness, friends." So there are a couple of issues specifically about the outcome part of that value equation that are really important. The first is how effective is effective. Here are a couple of examples from neonatology, and what we see on this graph is for the intervention of caffeine for apnea of prematurity. We have the cost of caffeine on the y-axis and the effectiveness of caffeine on the x-axis. And we see that you don't have to worry about why there are so many dots. They represent the uncertainty around this, essentially. But we see that all of the dots are in this quadrant down here where an intervention costs less and works more. So what we have is a therapy that is highly effective and costs less, and it's ends up costing less for each case of a survivor without neurodevelopmental impairment, right? So this is all driven by the effectiveness of caffeine. In contrast, here's prophylactic indomethacin for the same outcome, prevention of death and neurodevelopmental disability. And in this case, because indomethacin had not, in the trial that drove this, did not show itself to be effective. It was the same outcome in both arms of the study. We have a cloud of these dots that's widely spread, and we were unable to find that this was a cost-effective therapy. So the issue is, if you're not effective, you can't be cost-effective either. But beyond that, effectiveness also involves trying to decide what kind of outcomes we care about. So it could be whether a diagnosis is made, how many life years are made, or it might be things that are more difficult to measure: quality of life, anxiety, and regret, and so on. And so when we're thinking about using resources wisely, we want to think about all of these issues. Second variation is that expensive is not necessarily undesirable. So here we have the example of ECMO at term gestation to reduce mortality. ECMO is very, very expensive, right? It's one of the most expensive therapies that we have. But because it's also very effective, all of these dots are in a range where it's likely that the cost per life year saved is in this $30,000 range, which is in fact considered in the cost effectiveness world to be a very appealing level. Similarly, another very expensive therapy, nitric oxide. This is for prevention of BPD, and the caveat here is this is just from one trial in preemies. But still, a very expensive therapy was shown to have a cost effectiveness that is well within a range that would be considered appealing by economists and health policymakers. So theme number 2 is that expensive doesn't necessarily mean undesirable. ECMO, nitric oxide for certain indications, and then in this case, perhaps genomics. Third and final theme or variation rather, is that as with everything else in what we do in Vermont, Oxford, context and details matter. Probably going to hear a bit more of this, but if we apply genomics to screening an entire population, now we're generating a huge volume of expenditure for a particular degree of outcome, a particular number of diagnoses or life years saved. And that's going to have different implications than coning down in the NICU to a particular baby who has a particular problem. So is it screening or case finding that we're dealing with? What is the false positive rate? And if we have false positives or variants, for example, of that may or may not have clinical implications, does that lead us down a diagnostic cascade that can have economic implications? What about incidental findings? How do we deal with those? The counseling then becomes important. That has economic implications. And then finally, if we detect a case, but it doesn't change an outcome that we care about, that's not patient-centered, and it might also then be considered an unwise use of resources. I'm not going to answer, today. I'll leave it to others who are more expert in this field to answer the issues of whether the current state of the art in genomic sequencing is adequate to remove these from the equation, but just to know that it's not just a matter of determining one cost and one effect. So that's the overview. In thinking about new and expensive technologies, we need to use our resources wisely. We need to think about the effectiveness. That's key. It's probably more important than even the cost. And that's coming from a cost effectiveness person, that expensive does not necessarily mean undesirable, and that the context and details matter. Here are a few of the references that I referred to today. You can either click on the web link here or just scan this on your phone. Thank you very much, and I'll turn it over to Dr. Holm.
Thank you very much, John.
All
Go
right.
ahead, Dr. Holm.
Thank you. So it's nice to be here, and thank you for inviting me to this talk. So to kind of talk about something probably somewhat related, but on the other hand, also quite kind of different to John's talk, we're going to talk about the ELSI considerations in genomic sequencing. So there's economic considerations, but there's also kind of ELSI considerations. So just a reminder, what is ELSI? So ELSI is ethical, legal, and social implications. And it's really the impact and incidental consequences of basic biomedical and applied healthcare on individuals, families, and societies. And there's a whole research program at the NIH, the ELSI research program, which really looks at the ethical, legal, and social implications of genetics and genomic research on families, individuals, and communities. And so that's kind of what I am going to be talking about. So I'm just going to remind you that there's kind of 4 pillars of ethical principles that we think about. So the first is the best interest principle. So this is the idea that the clinician has a duty to act in the best interests of their patients. There's autonomy, where parents have the right to make decisions, or patients have the rights to make decisions about themselves. There's justice, so fairness in all medical decisions. And then there's non-maleficence, so we don't want to do any harm. So this is kind of straightforward if you have a patient and a clinician, but in pediatrics and in the NICU, you have a patient, it's a child, you have the clinician, and then you have the parent or guardian. And so now we're not in a kind of a two-way situation, but now there's some other parties that are really important, and that's really the parents and the guardian. So that kind of changes a little bit the ideas in best interest and autonomy, in that now not only is the best interest of the child, but the clinician making decisions based on the interests of the child, but parents really have a central role in acting in the best interest of their child. And then when we think of autonomy, there's not only the kind of child's autonomy to make decisions, which they really can't in the NICU. So the parents have the autonomy to make the decisions about themselves and their child. And then there's this concept of the child's future autonomy. So in the future, we kind of think about maintaining the child's right to make decisions about themselves in the future. So it gets a little bit more kind of complicated in children. In addition, in children and in the NICU, children don't give informed consent, as you're well aware. So parents provide proxy consent for their child. And this represents their child, and they decide what is in the child's best interest when they provide consent. And this kind of scope of this proxy consent is really limited because it doesn't really reflect the patient's true autonomy. So it becomes, again, more complicated in pediatrics as if children are not making decisions and not able to give consent. All right, so that's just kind of setting up a little bit of this kind of background. And the main thing I'm going to talk about today is return of results. So I'm going to also address a few other kind of issues in genomic sequencing in the NICU. So when you do, when you're in the NICU, you're sequencing, whole exome or genome sequencing on a baby. You're doing it for a reason. And essentially what you're looking for is a primary finding. So there's an indication for the sequencing. So the child has a certain phenotype and set of features, and you're trying to find the underlying genetic reason for those features. And when you do that, you may find genetic variants that are known to be associated with the phenotype. You may find genetic variants that are not known to be associated with the phenotype, but may have compelling genetic, biologic, and or pathologic features that implicate them in the patient's underlying phenotype. So this is why you're doing the sequencing. You're looking for an explanation. The issue is that there's then a lot else in the genome, and these are kind of the unexpected findings. So unexpected findings are genetic findings of clinical significance that are not related to the reason that you sequenced. And essentially these can be incidental. So this implies you weren't looking for them. So you were searching to find the cause of the patient's phenotype and you found something else kind of incidentally that was unrelated, but now you've kind of found it. Or it can be secondary, which means that you were looking for these kind of unexpected findings. So this gets to this issue when it comes to returning unexpected findings. Is there an obligation to inform patients of genetic findings that are certain kind of in quotes, so indicate a high risk for disease with a potentially high morbidity, mortality, and that are preventable and treatable? So it's a little bit of this kind of concept of, we found out something that maybe it's unrelated to your phenotype, but it may be important for your life, and is there duty kind of to return that information? And so the American College of Medical Genetics and Genomics actually put out a statement initially in 2016. This is a version in 2013. There's a version now in 2016 and an updated version, I think in 2021, really saying that, yes, there is this kind of obligation. If you find something that's really severe disease, easily kind of treatable, preventable, that you should return it. And so these are a kind of a minimal list of conditions that clinical laboratories should look for in return. So at least conceptually, these are conditions where there's a high penetrance. If you have the genetic finding, patients may be asymptomatic for a long period of time. There's an efficacious intervention. The positive predictive value is high, and it's not on the newborn screen because we've already looked for those. The two kind of important pieces of this is that initially they had suggested this is mandatory. It is no longer mandatory. Patients have an option to opt out, and there's no consideration of adult versus pediatric onset conditions in this list. So kind of getting back to this complexity when you're returning these type of results to families, secondary or unexpected results. So again, babies are not making an informed decision if they want these results. They are sequenced and their parents get the results. They don't have any choice about that either. It's important, I think, also to kind of consider the parent-child relationship. So does returning some of these kind of incidental findings, does it change your relationship of the parents to the child? Does it change their sense of vulnerability or bonding? Or are there other things kind of that get altered as that this may influence? There's also the familial implications of genetic results. So for many of these conditions on the American College of Medical Genetics and Genomics list, many of them are autosomal dominant. And so this is kind of more of a carrier, but the point is that we need to kind of think about the implications of genetic results and also kind of what results are appropriate. So is it appropriate to return adult onset conditions or non-treatable conditions or even carrier status in the context of kind of returning unexpected findings? So there are also kind of other issues when you think about returning genomic findings. So one is, what do people want? So some people may want to find out more information and some people don't. And so this kind of desire for information is important to consider what parents want or families want. The pre-test counseling and informed consent are also important. So part of the pre-test counseling for genomic sequencing involves discussing this option of getting unexpected results back, and do parents want that? And it's important for them to kind of understand what the implications are. What data to provide, so theoretically you could give them, much more kind of granular data versus just kind of basic genetic findings. And then how to disclose information when you're returning results, and the implications and the need for follow-up clinical care. So there have been some studies kind of looking at parents' views of benefits and concerns of receiving secondary findings, kind of in the context of not necessarily the NICU specifically, but the context of children with kind of multiple congenital anomalies who are getting a whole exome sequencing, and how parents view returning these findings. And I think parents basically see, get these kind of findings because they feel like, well, there might be a disease that they can prevent. There might be a family history of disease. And so they feel that there may be something that they will learn that will important in the context of their family. And oftentimes parents are also kind of information seekers, and they really feel the more information they have, the better. Parents also kind of brought up a number of concerns, and one is a potential emotional impact of results. Now, when we did our BabySeq study, which John talked about a little bit in terms of the economic findings, we actually did look to see if returning, in the context of screening, returning findings to parents had emotional impact, and it really did not. We did not find a significant kind of negative emotional impact, but parents do worry about that when they think about receiving secondary findings. And they worry about having one more thing to worry about in addition to having a child who's already sick. And then they have some concerns about implications, and particularly for life insurance, getting these kind of unexpected findings. So that's kind of talking about return of results. And I also wanted to kind of bring up some other kind of LC issues in return of genomic results that I think are important to think about, and kind of also are relevant to what John was talking about in terms of the economic consideration. And this is really this issue of justice and health disparities. So first of all, when we return results and do sequencing in families to make a diagnosis, there's oftentimes little treatment available for the conditions in these for these conditions, and that's also because of natural history may not be well known, and there just aren't any treatments available. So again, you're returning results where turning information to families that can't necessarily be acted on. So that's just something to kind of think about. And if there are treatment, there may be limited access to treatments. So treatments might be expensive, hard to get. Some newer kind of gene therapies or antisense therapies, these type of things are very difficult to find somebody who does them and to access them. And so there's that's kind of one of these kind of justice issues. There's also a sense maybe lack of access to social services support for families getting kind of diagnostic information back. And then again, like a little bit of what John was talking about is allocation of resources. And so I think it's just something we can kind of think about as we think, and it has kind of LC implications in terms of justice with doing sequencing in newborns. And then there's maybe a heavy financial impact on families beyond, including both the medical treatment, but also other type of financial impact. So if you have a child who has a lot of problems, and particularly if they're going to need some interventions, there's a lot of financial issues that parents have to think about in their families in terms of kind of dealing with these. And again, that ends up being somewhat of a kind of a justice issue. And then there's the issue of health literacy. So not everybody has, a lot of individuals don't have high health literacy. And so really kind of understanding and having access to all this kind of information can be really limiting for a lot of families. And finally, I just want to kind of bring up this issue of privacy and confidentiality and data sharing. And I think we often want to share data. We want to share data to try to make diagnosis. We want to share data with colleagues. But I think keeping in mind the difficulty of maintaining confidentiality of affected individuals due to the rarity of their condition, that it's quite difficult to do. And I think it's something that we have to kind of think about as one of the kind of ethical issues in sequencing babies in the NICU. So I will stop there, and we'll be happy to take questions in the discussion period.
Okay, so thank you very much to Dr. Zupancic and also Dr. Holm. And we're also going to welcome Dr. Russell Nafsinger now to the panel. Go ahead and chat in your questions, and I will be posing them to the panelists. So I think there was one comment more than a question. It was from Greg Miller, who stated it seems paternalistic to withhold results from patients. Dr. Holm, do you want to comment on that?
Yeah, we don't really withhold information from patients. So in terms of secondary findings, we give patients the chance to decide if they do or do not want that information. I think really for that reason, I think that people kind of in particular medical genetics feel that it's important to return information that we have to families. And that's really where the whole ACMG list came about, is that this idea that, yeah, we don't want to withhold information. We want to give back people information that might be important for them.
Absolutely. And so the other question was from Dr. Bartlett. Would you be concerned that a decision to withhold information could cause a lack of implementation of preventive treatments, thereby putting you at risk for legal action due to failure to inform of lab results in the future?
Yeah, so those are all kind of good questions of kind of liability, paternalism. So that's why we give parents an opportunity, we give them the choice. And if someone really doesn't want information, it doesn't seem right to force them to have information they may not want. And so again, the American College of Medical Genetics and Genomics initially had this list as being mandatory because they were so concerned about not returning something that could make a difference to people that they made it mandatory. And it was a lot of pushback in the kind of LC and genetics community on forcing people to have information that they may not want. And so that became an option to opt out. I think in my experience, I'm not sure I've ever had anybody opt out, but and people occasionally do, but most of the time people, as the question is kind of implicated, people do want information that might be important for themselves and for their family. I think the other thing to mention that one of these papers that kind of reviewing about parents' views, I think the only issue in the NICU is that sometimes parents feel overwhelmed already. And so now when you're giving them this option, do they want to find out about potential risk for things, cancer and heart disease and this type of thing in their child, it's not relevant to what the child's going on right now, that can feel a little bit overwhelming to parents.
Yeah.
So that is something to kind of consider when you're in the NICU, is that it may be difficult for parents to make those kind of decisions because they're so worried about the baby right now. It's a bit harder for them to think kind of out in the future.
Yeah. And I will agree with Dr. Holm that very rarely do I find parents want to not receive incidental findings. They usually want to receive the incidental findings. We actually had parents more upset that they wouldn't get findings. So we had a research protocol that would not return results initially to parents about themselves, and they were upset about that. So I think the atmosphere right now is people are more than likely to opt for more information than for less. I think Dr. Miller asked, is withheld information, if it's withheld, available if people change their minds in the future?
That's a really good question. I think it is available. I'd assume it's available. It's in the lab. So it's a matter of getting back to the lab where the sequencing was done. So that's a good question. I would assume you could go back and change your mind but I've never had that happen, so I'm not really quite sure how that would work. But presumably, theoretically, at least you could.
Yeah, theoretically, it is available. But with the fast pace of movement in genomic sequencing, frequently, technique gets better. So a lot of times at that time, it may be better to just reevaluate instead of just returning whatever you had in the past. I think Dr. Shadari says, I work with a low health literacy population, The pretest counseling for secondary findings just confuses the reason we're there, to identify why the baby is in the NICU and what we can do to save their baby. And we agree with that. With that in mind, I actually want to ask Dr. Notzinger now, in your experience, what group of patients have benefited most thus far from getting access to genomic sequencing? Are there certain patient characteristics that are routinely you routinely see in the different programs that you've worked with?
Yeah, thanks, Natalie, and thanks to Ingrid and John for setting up a really great discussion here. So most of the patients that have clinical access to rapid whole genome sequencing, so I'm going to speak from a perspective that's very centric to rapid whole genome sequencing, because that's kind of the core of what we focus on here at RCIGM. And so most of the patients that have clinical access to that test now are patients that are under 1 year of age and admitted to an ICU, usually a NICU. And there are a few reasons for it. One of them is was pointed out by John in his presentation in terms of the benefit. And so the diagnostic yield is really high in that population. There have been a number of studies, and the accumulation of many of the large ones shows that when we use rapid whole genome sequencing on patients in an ICU with disease of unknown etiology, the yield is usually around 30%, and there's a change in management or clinical utility with most of those that get the diagnosis and some that don't. And so downstream of all that clinical evidence and the large project that we had performed in California with 4 other hospitals across California, Project Baby Bear, doing a QI project on Medi-Cal patients here that looked at patients under 1 year old in an ICU. That's really kind of set the stage. And so now we start to see payer coverage for that population. And that's the most commonly supported demographic at the hospitals that we partner with.
Okay, thank you. Thank you very much, Russell. So a few, I think there's a theme forming in the chat right now. Dr. Harlinger says that although a specific genetic diagnosis may not have an available treatment, sometimes a specific diagnosis allows the family and treatment team to make specific decisions to shift to palliative care. This is an important advantage of using rapid whole genome sequencing in critically ill neonates. It shortens the diagnostic journey and gets an answer for the parents and the treatment team. And then there are some more questions about, information being clinically useful and the impact on patients getting insurance in the future. With that in mind, I actually want to bring up a question that came up in our last meeting, and somebody brought up, at that time we were talking about whole genome sequencing for newborn screening. They actually wanted to know that, since we only were including diseases in newborn screening for which we have a treatment or some kind of intervention that we can offer the family, in this day and age where we are have more advanced palliative care, what was the thought process of maybe that this is an antiquated idea that we should only be evaluating or sequencing patients or returning results for which we have an intervention or a treatment? So with that in mind, I want to ask Dr. Holm, what do you believe needs to be in place for return of unexpected results, i.e. the high risk for a disease with potentially high morbidity and mortality, and to become common practice?
Yeah, so that's a good question. So I have to kind of define what your question is. So I'm not quite sure. So are you asking in the context of newborn screening?
Yes, if we're going to expand testing, because at one point, people are feeling like, well, should we be just testing the child for whatever symptomatology they have right now and give them the diagnosis based on the symptoms and not give incidental findings, or not have family have to opt in and opt out incidental findings? So what if we expanded screening or sequencing to look for genetic abnormalities that may not have an intervention? What do we need to have in place to actually be able to expand something like that?
Oh, that's such a good question. So the study that I think John mentioned, the BabySeq study, that's what we did, and we're doing that now in a second version of that, is sequencing babies to look at kind of what it would look like if you did newborn screening, sequencing in newborn screening. And so I'm thinking about that there's a lot of things that may currently not be treatable, but may be treatable in the future. There's a whole kind of, diagnostic odyssey and knowing what's going on and having explanations for it. So there's certainly are reasons for potentially doing that. I think what you would have to have in place, I think gets a lot of to what John was talking about. I mean, it's a lot of kind of economics. You have to have, if you're going to do sequencing and get people this information back, they have to have somewhere to go. They have to have, the kind of clinical side of it. How do they find out that their child has something that may be at risk for in like 5 or 10 years? How do they follow that? What do they do? So I think that if you were to do that, there would be a lot of kind of clinical infrastructure that would need to be put in place, because now you would have a lot of people getting all sorts of information that right now we're not exactly necessarily sure what to do with. So that would be kind of my thought and what would need to be put into place.
Yeah. John, do you want to add to that?
Sure, I guess I completely agree with that, and it's those I think it's those hidden costs that worry people. But at the same time, we've done that very successfully for the traditional screening process. A positive result triggers the appropriate involvement, and even for very, very rare conditions, that's been successful. I think it is possible to put it into place. The other thing, though, that comes up, Natalie, was that what if there is not an intervention available for this disease? And that's an issue of that second theme of what is the outcome that we're interested in here. And I think we can, even in a program, we can outcomes however we want. So if palliative care is an outcome, then that is, it's totally, but the economic implications might screening for a condition that doesn't have an intervention available. We just have to decide as a society what we're willing to pay.
Yeah.
And I know that's something that you are much more expert in than I am.
But also interventions are changing. I mean, a lot of things that we never thought we would have interventions for, we're beginning to have interventions. This whole kind of the ASO therapies and all these kind of things, gene therapies that could be done at birth or shortly after birth. And so if you diagnose someone early on a screening, there actually may be more interventions. And as you go on, that will likely increase. So I think that also kind of plays into it.
Absolutely, absolutely. There is a question here that says, how much of a factor is cost of testing limiting use of whole genome sequencing in the NICU patients versus other factors like access to testing, genomic expertise to select patients for testing, interpret results, and how to use the information in clinical care? Russell, do you want to take this one since you've been involved with onboarding of many medical institutions?
Yeah, so the cost of testing, and particularly in the context of the way that most provider-payer relationships work for the financial obligations of patients in the NICU or inpatients, is a huge factor. It's probably the biggest factor that's preventing more hospitals from taking this on as a clinical test routinely. And so, it's not an inexpensive test. I appreciate John pointing out that the fact that it's expensive doesn't mean it's not effective or worth doing. But so hospitals would have to commit when there's not reimbursement, or there's at least not supplementary reimbursement immediately available, to outlaying a significant amount of money for this diagnostic test, and they'll have to appreciate, the clinical benefit, and that hospital's leadership will have to be aligned with spending their dollars that way. And it's a huge factor. Thankfully, reimbursement's picking up, and that's helping things too. And we're working closely with our partners to drive reimbursement locally in a handful of regions across the country, and that's all going well. But cost of testing, from my perspective, is probably the most expensive gate right now, or the most impactful gate for routine implementation of clinical WGS in the ICU.
Yeah. Dr. Lewis asking, can you comment on the dilemma of some hospitals' hesitation to allow in-house testing, which may be bundled in NICU daily care, when these kinds of studies would be covered in the outpatient environment?
I mean, so this is also a routine challenge that we work with, right? Because the way that reimbursement happens, it's unfortunately often been the case that these inpatients would wait till discharge to get some of these more comprehensive diagnostic tests like exomes or genomes, because they're covered on a diagnostic test basis in an outpatient setting versus bundled into a DRG or per diem rate or some other bundled mechanism inpatient. So that sadly has been the case. There's a lot of change ongoing now, thankfully, and there's a lot of data out there that support the utility and the benefit to the patient as well as the healthcare system for first line implementation in inpatient setting, but it's something we're still working to resolve.
Absolutely. There's some questions that are getting answered by others in the chat. So we'll be posting that. So just keep an eye on the chat because other people are answering some questions that you're posing in the chat. So Dr. Stepancic, this question will be for you. There is some data suggesting that nearly 8% of the US population receives low value services in a given year. How do we minimize the risk of a test like genomic sequencing further widening this gap?
I think that's something that we've been struggling with in quality improvement and implementation science in general. The idea that effective diagnostic test or an effective therapy might actually worsen something else that we really care about. We used to rising tide floated everybody up to a higher level, but it turns out that it can actually widen. I don't think that genomic testing is probably any different from any other new technology that we might use. In that, it requires us to be intentional about designing delivery systems that specifically target those issues. We can say, well, if I'm going to introduce genomic technologies into my healthcare system, my NICU, I am going to do it with a lens, with a focus on keeping the gap between individuals who have access and those who do not have access as narrow as possible. Now, the how to do that will depend on the system. It will depend on the NICU, but I do think that it has to be done up front. Otherwise, almost inevitably, those who have good insurance are going to get this paid for, and others might not, and that will worsen outcomes. And what I said at the top about the fact that we're doing this at the production of this technology in a very early part of the life cycle means that there's the potential to do that. We just have to act on as one of the parts of our value system that we include in evaluation and implementation.
Absolutely. With that in mind, Russell, you have dealt with private and public insurance. What are the salient concerns for covering genomic sequencing? What would push them to cover the cost versus not covering it?
Yeah, it's a good question. I guess it depends who the payer is. And so, as I pointed out previously, I think that one of the biggest challenges we have to deal with here is that care for these inpatients, the financial responsibility for care is kind of complicated by the bundled arrangement that has been set up. And so, we're seeing payers, including some Medicaids like Medi-Cal in California and some of the commercial payers that have medical policies saying rapid whole genome sequencing is medically necessary in the setting. And their medical policy is great, but if there's not some sort of carve out or supplementary payment mechanism back to the hospital, that's just, the insurance company saying, yeah, this is medically appropriate, fund it out of your own pocket, implement it however you think is appropriate for your patients. And unfortunately, that's not led to a lot of access, or not as quickly as you might think, in response to some of these medical policies.
Yeah. There was a question earlier, maybe I'll pose this to Dr. Holm, is do you think that a Bayesian decision-making algorithm, starting with clinical phenotype, will be helpful for frontline neonatologists trying to integrate the many considerations presented today?
Oh, wow, that's a good question. I like that idea. I mean, I suppose you're saying, right now, I think what you're getting at is a lot of these decisions are made kind of clinically based on clinical features and that type of
Yeah.
thing. Could we use algorithms? And I think most geneticists would not like to think that our services could be replaced by computer programs, but I think that there's and in a sense we'd have a little bit of programs because you kind of can put in a bunch of features into something like OMIM or something and come up with a diagnosis. But it's kind of an interesting idea, and I think people probably have worked on it to some degree to look at algorithms to assist in making a diagnosis. So interesting concept.
Okay. Let me see. There were some questions about touching how to contact families, but somebody pointed that out. If anybody didn't see it, the ACMG does have a statement specifically on that. Okay, well, time flies like usual whenever we're having fun. So I would like to thank our panelists very much for joining us today. And thank you also as an audience to be very active and have a lot of questions for us today. We invite you to join us in June for our next grand rounds, where we will be talking about genomics and health equity. So there are some of these topics that keep coming back. At that time, we will have Vance Bonham, the Acting Deputy Director of NHGRI, and also Dr. Lily Liu, who is a professor of clinical pediatrics and chair of the AEP section on neonatal perinatal medicine, join us to talk a little bit more about genomics and health equity. Thank you very much for your attention today. And just know that these sessions are also taped. So if you want to go back and revisit and look at them, or send somebody over to look at these lectures, they will have access online.